Hi, I'm Stephen Feldman. I'm a periodontist in Venice, Florida, and I'm the CEO of Accept Communication Technologies, LLC. And I'm very happy to be back here in Atlanta with Dr. Goldstein, Garber, and Salama at Dental XP. Today I'm going to, it's my desire to deliver a message about some of the changes I think that are occurring in dentistry as a result of CBCT, of CAT scans, of 3D. There's a large difference between going from a pixel, which is flat and square, and a voxel, which is a cube, but that's how it gives us volume. And I've been using CTs for 4 or 5 years now in my evolution of care with implant dentistry, but to date I've been sending the scans out to a scanning center, and so it was a very specialized experience. Once I had the CT placed in my office, really my world changed completely, and my ability to diagnose anything and everything in dentistry changed. So as I see it now, where we have a digital pan, we have all that, from my point of view, why irradiate a patient with a digital pan or an X-ray where you can't get the data? In my opinion, get the data if you can get the data, because that's what they're there for. The reason I'm saying that is because dentistry is basically asymptomatic and subclinical, which means that we rarely have any early warning signs. It's very similar to the heart and the lungs, where you have to pump blood, you have to breathe, and you have to eat food and drink water. So those areas really it's rare that there's an early warning sign, and if there's a problem there, you won't know it until it's too late. And it's very similar to the mouth, where the mouth is actually, it seems like it's an orthopedic model, which it is physically, which means you have hard tissue, ligament, and hard tissue. In the mouth, it's hard tissue, ligament, and tooth. And in the knee, for instance, it's hard tissue, ligament, and bone. When the ligaments of the spine and the bone and the hip and the shoulder are bothersome, they always hurt. They hurt until the patient can't stand it anymore. In the mouth, you can have 80% bone loss, around half a tooth, with ligament completely damaged, in fact gone, and there's no pain at all, and the patient is often unaware of any symptomology whatsoever. So because of that, the necessity to find out what's going on and what they don't know, I believe, and I'm seeing in my practice, to be very, very, very important. And honestly, I've missed it for years and years. So what I'd like to show you is what we do now with our software, which actually documents all the data from the CBCT and places it into Accept, and then we evolve care from that. So essentially, whatever we do is based on, I guess you could say, the science behind the treatment plan, and that's what we do. So let me show you this. This picture that you're seeing right now is actually a referral letter from a restorative dentist. This is a crown, and he's recommended that crowns perhaps be placed. He wanted me to evaluate them periodontally as well as for implants. As you can see, implants were recommended to be placed in the maxillary. In the maxillary, sinus with sinus grafts in the maxillary right and left, and the teeth are all numbered 2, 3, 14, and 15, and so on and so on. And that's what he recommended. He was also recommending 2 other crowns on the bottom here in 20 and 21 and 28 and 29. And he was so kind to go ahead and write a little note about this, kind of explaining what kind of care he wanted. And it was referred to me. As you can see, the card here and the name here are out, so we've made this anonymous. But this is actually the referral letter that he sent me. And he was hoping that I could place sinus grafts in these largely pneumatized sinuses. So when I received this, and this is from his digital pan. So when I received this, I created a document that looks much like this. So the patient came in. This is a view of the pan view from the CBCT. This is the look tool, which shows underneath it. When I double click on it, it shows what I recommended or the end in mind. So click, double click. Very simple, very easy to talk with. And I went into the CT, and right now the CT we purchased, we placed in the office, was the Kodak 9500. And the reason I purchased that was because I wanted to find something that I could evolve care with, not just in implants, because I felt that implants were reasonably simple in terms of, is there enough bone, is it deep enough, wide enough, thick enough, and so on and so forth, to place in implants, or do I need to do some advanced bone grafting? To me, that wasn't a very difficult decision to make, and it wasn't the only reason for a CT, because since dentistry is asymptomatic and subclinical, and mostly what's wrong, we're not going to know until it's too late. I wanted to find out what else was going on in all the rest of their teeth, and it was my desire, as they do in medicine, to give patients clean bills of health where they were clinically normal, or at least clinically normal to that date. And I'll define that for you in a moment. So I open up the CT, and this is the reason why I chose the Kodak. Because in Kodak what I can do is my staff takes these, of course, and I can actually scroll, and what you're seeing right now is me scrolling through the pneumatized sinus and follow the blue line. And as the blue line starts to move forward, you can see how we planned implants with this, just as it touches the edge of the tooth, you can see the crown of the tooth, or the very dense area of the crown of the tooth. And I show this to the patients, and I explain to them it's like a loaf of bread. Take a piece out, and this piece right here is that, and put it back in, or a book, and put it back into the bookshelf. But they do understand it, and they're riveted to it. And the reason I do that is to give them a clean bill of health. But there's another reason. Because dentistry or problems in the mouth are really asymptomatic and subclinical, like they are in the heart, like they are in the lungs, and many other areas of the bodies where you're not supposed to feel anything until it's too late. The patients are not here in necessarily a cognitive state where they're just wanting to talk about their problems. They're actually very nervous, fearful sometimes, and I think the reason for that is in cardiology and the other areas where you have asymptomatic subclinical organ systems, if you will, is that the adrenaline pump is on. Because those areas, by definition, if you're asymptomatic and subclinical, the adrenaline pump is on, which means our patients are coming in to some degree in fight or flight. Now, if they're in fight or flight, and your practice is slow, and you're financially somewhat challenged or feeling that way, then you're in fight or flight. So, in my opinion, that's a difficult time to talk to patients. So what we like to do is we like to disarm them with reality, and that's what we're seeing with the CT and with Accept. When we show them their care and they start to see it, and they start to evolve it as I am right now when I'm scrolling with the mouse, the patients, you can see them slump, and you can see the adrenaline pump almost go off, and they're very comfortable because they're actually watching what's going on in their mouth and where they're healthy and where they're not. And I just slide through the whole mouth and I show them exactly what's going on, and if there's widening of any ligament, how the root canal teeth are, and I really explain this to them. And it's very simple for them because they get it, and they do point it out, and you'd think they couldn't, but they can. And I think it's a testimony really to this Kodak software, because I'm able to do this on the fly right in front of the patient. My objective, of course, is to get that adrenaline pump off. My other objective is to do this. As I roll through the mouth, I'm going to find things. And when I find things, I'm going to document them. So, for instance, here, when I place in the software, you can actually place the implant and plan for it. So here, I'll show you an implant. I'm going to show it to you in a second. So here's an implant coming into view, and it was planned through the implant section of their software. And for me, it's very uncomplicated. I go right to my favorite. We've placed Zimmer implants here and went right to it, and very quickly placed these implants in. Now, once I have this, what I do is I make this larger, which is very simple, and then I capture it in our Accept capture software, and I copy it, and then I paste it into our software, the software you saw initially, this Accept software, and I just click paste, and there it is. There's my implant that I'm placing. So what you're seeing here on the screen very simply is in number 14, this is the implant I'm placing. In number 13, this is the implant I'm placing. In number 12, this is the implant I'm placing. In number 3, this is the implant I'm placing. You can see where the sinus is pneumatized, how much bone there is, and so on and so forth. This is actually what goes up right before my surgery. So when I'm about to go into surgery, my staff has actually taken all these pieces, placed them out there. I don't have to go back in to the DICOM and take a look at what I'm doing. I've already got it here documented on my paper. Now, the reason for this is twofold. Number one is I can go into the surgery and don't have to go in the DICOM. I said that. The other reason is a little bit more, I think, complicated. It proves that I went through the complete DICOM, gave them a clean bill of health, went through everything, and I documented everything that was germane in their mouth or anything that was challenging, and we had to either address now or possibly address later, but at least I went through it. So it does take informed consent to a completely different level. From the patient's point of view, they're very excited that we've looked through everything, and they think it's thorough, which it is. And from my point of view, this is almost, this is our test. This is our asymptomatic subclinical test. In cardiology, it's the cholesterol test and everything else. In dentistry, it's CT, it's 3D. And in order for 3D, in my opinion, to be effective, and we find it to be most effective, we use accept here because it documents all the 3D. And then after it documents, as you can see, we can place implants in and actually show the patient the evolution of care or the end in mind. And they get it. This is just a very large view coming out of accept, showing them an implant, how the abutment goes into the implant, and how the crown goes over the abutment. So there are even pieces, creative pieces, and you can create them yourself of patient education material, if you like. From this point, I do the surgery. And that's the clinical photos of the surgery. And here is the actual surgery. And here it is. So this showed the views during the surgery. These were open, showing the views of where the implants were, and I'll show you that in the 3D. This showed the implants placed, and we used infused. And some of the areas we battered it with Pyros in order to get some volume, and some of them we didn't, because I wanted to see where plain infused or BMP2 or RHBMP2 can be used and with immediate placement, and whether it's necessary to batter it. So I kind of split it up here, and you can see right over here, if you can see it, this is where you can see the Pyros on the BMP2. Here you can't because there wasn't any, and on this side there was. So I battered this side, didn't over here on 12, 13, and mostly did on 14 where it was almost fully pneumatized. At any rate, these implants are still in place. This is actually the clinical photos that we take on the fly during the surgery. We use the Kodak 1500 intraoral camera, which is now wireless, and we take all these pictures. My staff does. They kind of hold with two hands the wand, and they take the shots. And I think, from my point of view, the resolution here is surprisingly good. I'll show you. There we go. And I'll bring it back down. So in our software, if you press on minus, it gets smaller. If you hit plus, it gets larger. It's very simple and allows us to do this quickly. So I do this, and my staff goes ahead and adds these little notes and so on and so forth to make this look like what it is. And so we document all our cases very simply. We never used to before until we got this intraoral camera, and it also takes movies, which we do as well. Now, back to the CT. After I planned for the implants, I went through, again, with the end in mind and with a clean bill of health in mind. I need to evolve care on the lower arch, or at least diagnose the lower arch to see if there's anything going on. So these are moved to orient us towards the lower arch, and we're going to begin with tooth number 18, and let's see what it looks like. So as I'm scrolling through 18, I would like you to focus here on this level of bone here. This is the level of bone. We're going to be going into a tooth very quickly. You're going to see the root begin to appear. There it is. And you'll see the root disappear because we're going into the furca. And you'll see that drop slightly. And the next root come in. Now let me show you the next tooth. And then I'm going to show you how one is a furcation involvement and one is not. Do you see how high the bone is right here? Now I'm going to back up and watch this spot drop. There we go. So here it goes. Now I'll roll through this for you. And that's essentially showing what a furcation involvement looks like. And the next tooth, you see how high the bone is right here? See how high this is? Now you see how low this is? This is demonstrating furcation involvement, which you normally are very difficult to see. I haven't been able to see it on other CT software. It's just not that accurate, or it's not that friendly to go look through this. And from this point on, I'm just going to scroll through these teeth very quickly, and I can bend the line to see everything. Now while I'm doing this, I always go into this view, which is the 3D view. And it shows where my implants are, and it shows my lower teeth, as you can see. And I can go ahead and look into and see the furca from here by just going like this. And you can see the furcation involvement, and you can see where it's through and through, right there. And if I wanted to capture that and document that, I would just use our capture tool and accept, document the furcation, copy it, and simply paste it into our document, perhaps right down here. Just paste it, and maybe double click on it, place it here, and then open it up, and there it is, documenting it. That is really what we call the evolution of care using Accept and Kodak 9500 CBCT. I highly encourage you to take a look at these products, as they do take informed consent and diagnostics to a whole new level for our patient care. I think it's the new direction that dentistry is going into, and I thank you very much for your time.